This is The Rounds Table. Welcome back, listeners. A new solo episode. It will be short and hopefully sweet. I will be covering once-weekly semaglutide in adults with alcohol use disorder, a phase 2 randomized trial. This was published in JAMA Psychiatry, actually back in February 2025. This has got to be the first time that JAMA Psychiatry has led to a trial that is potentially of relevance to our Rounds Table listeners. So a quick backdrop, and this is reinforcing things I previously learned and forgot, but the background of this manuscript nicely lays out the fact that alcohol use disorder remains a leading cause of morbidity and mortality and accounts for 3 million deaths globally each year. Up to 1/3 of US adults, and I'm sure it's similar for Canada, meet criteria for alcohol use disorder at some point in their life, but less than 10% will get treatment for it, and maybe 2% will receive some form of a pharmacotherapy for it. This kind of makes sense because we know that the existing medications that help with alcohol use disorder, they don't always have the best sort of benefit to side effect profile, and many of the medications are actually off-label indications. So gabapentin, for example, is one drug that's used for alcohol use disorder. That's an off-label use of it. Now, there are lots and lots of anecdotal data that suggests GLP-1s lead to a reduction in alcohol intake and cravings. I've seen this clinically. I've seen this among patients who say, ever since I started Ozempic, Semaglutide, Rybelsus, insert whichever version of Semaglutide, that they report just a much lower desire to drink alcohol. I've seen some patients who drink multiple standard drinks per day and go down to like maybe one drink a week. That, of course, is anecdotal. There's been some observational studies that have supported this, but there really hasn't been a randomized trial. And that is, of course, where this study comes in. So the authors wanted to conduct a phase 2 placebo-controlled trial to identify whether or not there might be some signal that GLP-1s, in this case semaglutide, could potentially be effective for adults with alcohol use disorder. So this is a, as noted, phase 2 double-blind trial. It was short at only 10 weeks in total. Who did they include? Adults aged 21 to 65. They had to have DSM-5 criteria for alcohol use disorder, and part of that was based on number of drinks per week. So for females, it was at least 7. For males, at least 14. Some key exclusion criteria: if they were currently on treatment for their alcohol use disorder, if they were actively seeking treatment and about to start something for the alcohol use disorder, if they had previously been on a GLP-1, if their BMI was less than 23, as well as if they had another substance use disorder apart from alcohol. There were a few other exclusion criteria, but those were kind of the most relevant and salient ones. So the intervention: once weekly semaglutide at a dose of 0.25 milligrams per week, which is the typical starting dose, for 4 weeks, and then up titrated to 0.5 milligrams per week for 4 weeks, and then finally up titration to 1 milligram per week. Just as a quick frame of reference, that's sort of in and around the dose you might see for adults with type 2 diabetes. For obesity, you can see much higher doses being used, and there's certainly a dose-dependent weight loss that's observed as you go to higher doses. Comparator was placebo. The outcome was something I had never heard of before. It's the laboratory alcohol self-administration measured at pre-treatment and post-treatment. There was also lots of secondary outcomes, mainly related to self-reported alcohol use. So let's just dig in a little bit on this primary outcome. The way that it works is there's a standardized protocol that is used to estimate voluntary consumption and ability to delay drinking in a lab setting. It kind of reminds me of that marshmallow test that you might have heard of, where they had like a child in the room and there was a marshmallow, and they sought to determine how long could the child go without eating the marshmallow. Okay, so a bit more details on this. Participants were presented with their preferred beverage and brand and could elect to delay drinking for up to 50 minutes for monetary reinforcement. How much, I'm not sure. And then thereafter, participants were instructed to consume alcohol at their preferred pace to achieve preferred effects over the next 2 hours. The available alcohol amount in grams was determined based on pre-specified maximum breath alcohol concentration. So over multiple time periods, they had like a breathalyzer, for lack of a scientific word. So this was measured every 30 minutes after. And then they could estimate the volume consumed of alcohol. So not the world's most straightforward primary outcome. Okay, let's go on to the results. 500 patients were eligible. 48 patients were randomized, so that's like 10%. 70% were female. Average age was 40. Average BMI was 32. Average number of standard drinks per day was 3 per day, and the average hemoglobin A1C was 5.1%. 42 of the 48 patients completed the trial. So for that primary outcome, what did they find? Well, on brand with the messiness of the description, the results are also messy. So listen, this is what it said, and I quote here: results of residualized change models indicated that semaglutide reduced post-treatment lab consumption with a medium to large effect size for grams of alcohol, beta negative 0.48. I don't know why the authors reported results like that. That beta number is totally not interpretable. You got to exponentiate it so we know what does this actually mean. The figures, though, do provide more informative and easy to understand results. So you can sort of see that the amount of alcohol that was consumed during this self-administration in a lab was approximately 60 grams in the placebo group, and then approximately 35 grams in the semaglutide group. And then similarly, the breath alcohol concentration in the placebo group was approximately 0.9 grams per deciliter, and almost half that in the semaglutide group. As noted, there was a number of secondary outcomes where they asked patients to self-report how much they were drinking over time, and generally observed larger reductions in the semaglutide group compared to placebo. And unsurprisingly, patients in the semaglutide group lost more weight than the placebo group. So there you have it, a small and short phase 2 trial. Those are some of the really important limitations here. I think another limitation is that we would want much longer term data than just 10 some odd weeks. I think this is definitely hypothesis generating, and it supports the observational data and the clinical anecdotes that many people have observed, whereby their patients say after they start a semaglutide, their craving, their desire to drink alcohol really diminishes, and often their intake does as well. There, of course, needs to be a larger phase 3 trial to know, is this robust or not? But when you think about it, it's going to be hard to do that study because at the time of recording this, October 2025, semaglutide is indicated for adults with diabetes. It also has an indication for adults who are obese. That alone is like 1/3 of the North American population. In the US, the FDA recently extended its indications to include NASH, or what is now called MASH. So we're kind of getting up to like 35% of the North American population has an indication for this drug. And then I actually thought the conclusions were interesting to read. So here they are from the authors. Since the FDA approved the first alcohol use disorder medication, that was disulfiram, back in 1951, only 2 medications, naltrexone and acamprosate, have received subsequent FDA approval for alcohol use disorder. So the rate of one new approval is like every 20 to 25 years. I just thought that was, provocative couple of sentences. They go on to say, should additional phase 2 and phase 3 clinical trials support repurposing one or more GLP-1s for alcohol use disorder, these treatments could have broad clinical infiltration with potential to bypass many traditional impediments to the uptake of alcohol use disorder medications. Yeah, that's probably fair. They go on to say these possibilities call for larger clinical trials to evaluate the efficacy of GLP-1s and other incretin therapies for alcohol use disorder. Given numerous GLP-1s at various stages of development, future studies need not be limited to a single medication. I totally agree with that. So it'll be interesting to see what comes of this, what other studies show. And I'm curious to hear from listeners if this sort of aligns with what they've observed when they've been prescribing GLP-1s. It would also be great to hear from any clinicians that listen to our show that have expertise in substance use disorder to see what do you make of these findings, and Does it align with your clinical practice? Are you already prescribing these drugs? All right, listeners, that's it for me. Stay well and take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.